This is an instructional video to teach healthcare providers how to perform the Active Movement Scale examination for infants with brachial plexus birth injury. Brachial plexus birth injury is an injury to the C5 through T1 nerve roots that occurs during childbirth and presents as an upper extremity weakness or paralysis. The number of nerve roots affected is variable, but is important to determining an infant's prognosis and making treatment decisions. A good clinical exam is needed to determine the nerve roots affected, and thus an infant's prognosis and treatment options. Infants can be difficult to examine. The Active Movement Scale, or AMS, is a validated clinical tool that gives us a systematic way to perform a comprehensive exam of an infant with a brachial plexus birth injury, or BPBI. It allows us to do several things. 1. Evaluate the upper extremity motion and strength of infants with BPBI. 2. Determine which nerve roots are affected. And 3. By evaluating infants serially at month intervals, we can assess how their nerves are recovering. The purpose of this video is to teach healthcare professionals how to perform the Active Movement Scale. The Active Movement Scale evaluation was developed at the University of Toronto by physical therapist Christine Curtis and colleagues. It has been validated and widely adopted for evaluation of infants with brachial plexus birth injuries. The AMS allows us to evaluate 15 upper extremity motions. These motions are shoulder flexion, shoulder abduction, shoulder adduction, shoulder internal rotation, shoulder external rotation, elbow flexion and extension, forearm pronation and supination, wrist flexion and extension, finger flexion and extension, and thumb flexion and extension. AMS scores at each joint are based on 2 factors. First, determine whether the motion is being performed with gravity eliminated or against gravity. Secondly, determine what percentage of the full arc of motion the child can achieve. By placing infants in different positions and stimulating them to move their arm with toys and rattles, we can determine the percent arc of motion and whether that motion is performed with gravity eliminated or against gravity. With these 2 pieces of information, we can assign that motion a score from 0 to 7. We first look at what arc of motion a child has with gravity eliminated. If they have no motion with gravity eliminated, they are scored a 0. If we can feel the muscle contracting but there is no arc of motion, then the child is given a score of 1. If the child has less than half of the full arc of motion with gravity eliminated, we give them a score of 2. A score of 3 is given for greater than 50% of arc of motion. If the child can achieve the full arc of motion with gravity eliminated, we give them a score of 4. To give higher scores, the child must demonstrate motion against the force of gravity. If they can achieve less than half of the arc of motion against gravity, then we give a score of 5. If they can achieve more than half but less than full motion, the score is 6. Full motion against gravity achieves a score of 7. All 15 functional movements of the AMS can be observed by guiding children's play in 3 positions: supine, or lying on the baby's back, side lying, and sitting up, often on the examiner or the parent's lap. These positions enable the examiner to eliminate and add gravity to each of the motions. Let's demonstrate how this works. We start with the infant supine to assess their shoulder abduction and adduction with gravity eliminated. We look at what percent of the arc of motion the child can perform and grade their best arc. If no joint motion is observed and no muscle contraction is palpated, the score is 0. If no visible joint motion is observed, but we can palpate muscle contraction, the score is 1. Active abduction less than 50% of the arc, or 90 degrees, is scored a 2. Greater than 50% is scored a 3, and full motion is a 4. Grading adduction is similar. We position the child's arm abducted and assess their percent adduction. For example, this child has full adduction. We give them a 4. The last motion we assess in the supine position is anti-gravity triceps motion. Because this motion is against gravity, The score starts at 5 for less than 50% joint range, 6 for greater than 50% joint range, and 7 for full elbow extension against gravity. We next position the child lying on their side with the affected arm up. The only motion we assess in this position is gravity-eliminated shoulder forward flexion. Less than 50% motion or 90 degrees is scored a 2, greater than 50% a 3, and full motion a 4. The last position we place the infant in is a sitting position. We assess all other motions in this position. We start with an assessment of anti-gravity shoulder abduction. We grade this using the same concept of percent arc of motion, with less than 90 degrees representing less than 50% of the arc of motion and receiving a score of 5. More than 90 degrees but not full arc of motion receiving a score of 6, and full motion receiving a score of 7. Because it would be unsafe to suspend a child in the air to test anti-gravity adduction, we assess if the child can adduct their arm against gentle resistance. If they can adduct their arm against resistance, we give them a score of 7, the highest score for anti-gravity motion. We then look at anti-gravity forward flexion using the same scoring criteria. The last shoulder motion we assess is shoulder external and internal rotation. We first assess gravity-eliminated rotation. For shoulder external rotation, the child starts an internal rotation, and we assess how much they can externally rotate their shoulder. For gravity-eliminated internal rotation, the child's arm is positioned in external rotation, and we determine how much they can internally rotate. To assess anti-gravity rotation, we apply resistance to the child's arm to determine if they can internally or externally rotate against resistance. If they can rotate against resistance, we score their rotation a 7, the highest score for gravity-eliminated motion. Next, we assess gravity-eliminated elbow flexion and extension. Note that even though the child is in a sitting position, we can assess gravity-eliminated elbow flexion and extension by abducting the child's arm and supporting the child's upper arm. Elbow extension is graded by starting the child's elbow in a flexed position and observing how much they are able to actively extend their elbow with gravity eliminated. Elbow flexion is graded similarly, except the elbow is started in extension. Let's move on to the assessment of the wrist. To examine gravity-eliminated wrist flexion and extension, the wrist is positioned so flexion and extension are parallel to the ground. To assess wrist extension against gravity, the forearm is pronated and the wrist flexed. To assess wrist flexion against gravity, the forearm is supinated and the wrist is extended. Let's discuss assessment of finger motion. Finger motion is evaluated at the MCP, metacarpophalangeal joint, and we grade the finger that demonstrated the best motion. To assess finger extension against gravity, the forearm is pronated and the fingers are flexed. To assess finger motion with gravity eliminated, we position the forearm in neutral, so flexion and extension of the MP joints is parallel to the ground. To assess finger flexion against gravity, the forearm is supinated and the fingers are extended and the percent arc of motion is assessed. Thumb motion is assessed similarly. The forearm is positioned so thumb motion is parallel to the ground to assess gravity-eliminated motion. The forearm is repositioned to assess thumb motion against gravity. Both thumb flexion and extension against gravity are scored with the palm facing upwards, so the initial arc of motion is toward the ceiling. The last motion we assess is forearm pronation and supination. To assess gravity-eliminated forearm rotation, the child is sitting with the shoulder and elbow held in 90 degrees of flexion, and the child's hand is stimulated in the directions of pronation and supination. To assess anti-gravity, we position the upper arm adducted and the elbow flexed to 90 degrees. To test pronation, forearm is fully supinated and movement of the hand is directed towards full pronation. Supination is tested in the opposite way, with the forearm starting fully pronated. Let's review some key points in interpreting the active movement scale examination in infants. AMS scores at each joint are based on two factors. First, determine whether the motion is being performed with gravity eliminated or against gravity. Secondly, determine what percentage of the full arc of motion the child can achieve. "50% joint range is considered 90 degrees for shoulder flexion, abduction and adduction, and internal and external rotation, as well as elbow flexion and extension. Neutral position of the wrist and forearm is considered 50% arc of motion for forearm pronation and supination, and wrist flexion and extension." Thank you for your attention and interest in learning how to interpret the active movement scale evaluation for infants with brachial plexus birth injuries.